So let us start our session. Good afternoon to all. Warm welcome you all to the today's TIPSACO session. Today's session on psychosocial issues in palliative care. So I am happy to introduce Ms. SHERIN WILFRED. She is our senior medical social worker. So she is handling this session today. So I invite her to take over this session.
Thank you, Shri. Actually, okay, hi all. Good afternoon. So I'll be discussing about psychosocial issues in palliative care. So we'll start with a story, a patient story, and I want you all to respond to that after that. So, 27-year-old female, Ms. D, has been diagnosed with CA rectum on 2014. She had chemotherapies and radiation followed by colostomy. She had been referred to Pallimedia for pain management. During the time of registration, she had severe pain, infection, and foul smell from the colostomy site. She looked very anxious and scared and had no idea about palliative care. So, suppose that you happen to meet this patient, and what all will be the areas you would look upon? You can unmute yourself and answer. Anyone?
The first thing we will look on whether the patient has come with the relatives and does the relatives know about her situation or not, and how they are taking care of her during the thing, because she looks very anxious and scared, and she's not having idea. So the site of infection is foul smelling and the colostomy site. So we can ask her whether she's getting her daily dressings, or how about her daily dressings, where she has to go, how far is the hospital, her financial status, and what is her support from the family. We consider these, I guess.
Okay, that's very good. Any other answers?
But first of all, same setting has to be taken care of. That a quiet environment with privacy to deal with, to make her comfortable, and then followed by what is his understanding of the disease, what is her ambitions to take care of that, and what is her expectations. We can deal with that, and accordingly we can proceed.
Thank you. So we mostly focus upon the physical aspect, like we look upon whether she had any she have any infections, or the foul smell, whether the wound is taken care of, and then we look upon the social aspect, how she came, or the family members, are they taking care of her? Okay. So what we did in this case was, like in this patient, what we did was, her problems were not only physical but also psychological, emotional, economical, and spiritual. We identified that through the conversations with her. So it was reported that she was unclear about her prognosis. She doesn't know what's going to happen in the future with this colostomy bag. And she's also having difficult relationship with her husband and family members, his family members. Actually, after getting diagnosed, they started to blame her, and they mostly criticize her for being diagnosed and having a colostomy bag. So this was literally affecting the bond between her husband and herself. And due to her condition and frequent hospitalization, husband was not able to go for work, which directly affect their socio-economic status. Actually, he was the only breadwinner of the family, and uh, uh, and he is the primary caregiver for this patient. So whenever she had been admitted in the hospital, he stays there as a caregiver, and thus he is not able to go to work. So this also made constraint in their family relationship, and also she felt as a burden for the family. She was worried about bearing the educational expense of her two children. Actually, she had been taking chemotherapies and radiation, which is a bit costly treatment here. And in addition to that, she was more anticipating that her children's education fund will be relocated to her treatment. And she lives in a very rural area. That means that she had very difficult traveling convenience, that going to a nearby hospital or specialty hospital is very difficult for her. And being with a colostomy bag, she cannot go on a like she feel hesitant to travel in a public transport, because people may look at her, and that was the main concern. She was very hesitant, and that was the issue. Then she was in extreme spiritual distress, because she, being a good being a follower, she had a strong belief in her God, and but still she started to have that spiritual questions like, why me? That was the main factor which we identified, which is literally relating to the spiritual suffering. So that was very prominent in this patient. So it is said that Colin Murray, he says that cancer can affect a family in much the same way as it affects a body, causing deterioration if left untreated, and it's also financially making them constrained, and even emotionally making feeling that patient may have anxiety or leading it to depression. So it is not only physical problems, but also relating to the psychological, then social and economical factors. The pain reported by a patient compounded by his life circumstances. Like if the patient is having strong support from the family, he may have emotional stability. At least he'll feel that, okay, I'm getting care from my family. I have that. So that may affect as a coping, one of the coping mechanism for patients. Okay, as a clinician, my responsibility is to assess the contributive factors leading to total pain. Total pain in the sense which look upon not only physical but also psychological, socio-economic, and spiritual. So maybe the patient may say that they are having 10 on 10 pain. Even with the medication, sometimes we experience some patients does not get adequate pain relief. But later, having an interaction with them, we identify that this pain is increased due to the psychological distress. So adversely, it can affect the total care of the pain. And what we usually like when we do a psychosocial assessment, what the main aim is to identify problem areas, like which area it is, maybe psychological or social, family issues, then is they are having any isolation behavior. So these areas will be assessed, and what we do is we'll collect information, identify honoring strengths, resources, and needs. We'll not only identify the problem, but also find alternative solutions to tackle those issues. Whether we can find support from the community or any other supportive groups, such resources were explored. Then assessing and gathering the information is an ongoing process. For example, the patient may, when they come here, maybe the first priority will be like pain relief. So when we address that, later they'll develop with their fears about they doesn't know about the diagnosis or prognosis. There'll be collusion. So it's different in each time. So we have to understand that this is an ongoing process and we have to do it very frequently. We have to sit with the patient and to understand their concerns and try to solve them with the supportive help. Psychosocial assessments need, psychosocial needs of patient and family caregivers often change over the course of illness, which was changing like since it's an ongoing process, it may change. The most possible psychosocial impact of illness is like anxiety, fear, grief, guilt, depression, and suicidal ideation. They'll be anxious about like when they come to know that they have having a chronic illness. The first thing will be anxious. Maybe they have fear about their family, like what is going to happen, how they are going to manage all these situations, and how they are going to cope up with the situation. And then they will also develop grief, which can be anticipatory grief, like fearing about the future, that how maybe they're going to die. So these are anticipatory grief. And later, maybe they'll also develop guilt feeling that I'm being a burden for the family, and my family is suffering all because like they are not able to go to school, my children are not able to go to school, and my husband has to stay here with me. So these develop some guilt role in the patient, and which can lead to like depression with the leading signs are like feeling of helplessness, feeling of hopelessness, and feeling of worthlessness. Is the pure symptoms that is seen in depression. And when it comes severe, it can lead to suicidal ideations. Like they'll find that committing suicide is one of the best choice that they can escape from this reality. And when talking about dignity, what usually happens is like actually Dr. Harvey Max is a Canadian psychiatrist. In his book Dignity Therapy, what he said is like the inability to acknowledge personhood or the insensitivity to acknowledge personhood can be psychologically devastating. For example, this patient may be having a decision-making role in his family, or he is the breadwinner in the family. But what when they are stuck with a life-threatening situation, like having a diagnosis, what really happens is they lose their role in the family. Actually, they have to be dependent, or even in some medical setting, what they feel is like they are not treated as person; they are treated as a container of disease or a patient. Mostly referring with the diagnosis, and we usually look upon the physical things and trying to treat that. So there we are not respecting the dignity of the person. So if if we are able to look upon that, we are giving a sense of hope, like we are respecting their values. So dignity is another important factor that always we should keep upon mind, that they are not only a patient but also a person. So where we work with the developing the empathy, I hope you have attended the communication skill where we learned about empathy building. So these are the most important things in dignity we have to look upon. Then he himself explained that Dr. Harvey himself explained that people experience a loss of dignity having significant high rates of depression, anxiety, and feeling of hopelessness, which is really adversely affecting their psychological well-being also. This lady happened to have a colostomy bag, and she's scared that okay, that is like her children is like getting affected, and the other family members are having feeling towards a negative feeling, in the sense she have to clean the colostomy bag every day, and she feels that the other people will find out that she is hiding it under her dress. So these were all already like adding distress to her psychological issues. And one question, what really we can, this is a dignity related question which we can ask to our patient is that we can ask them directly, what do I need to know about you to help you better? By asking this, we are giving a opportunity for them to explain about their concerns and their solutions. Actually, what we find is like whenever we go for, we have an interaction with the professional, I mean healthcare professional, we have a tendency to suggest lots of solution for the patient. But it may not be appropriate for the patient because every individual have different experience and they have their own coping mechanism. And what really happens is when we suggest our personal experience to them, our best solution way, that may not be working for them. So by giving the opportunity to think about their problem and find a suitable solution for their problem is the best way we can help them. So we should always think about give the opportunity for the patient to talk about their solution rather than we are suggesting them. So it's in research it is said that in one in five suicide in India is a person suffering from committed by a person suffering from chronic pain or advanced illness. It is also because like they feel that this is the end and nothing can be improved and they lost their future. So this adversely affect them to take them to think that committing suicide is the best solution for them. So they may be feeling guilty about being a burden of their family. They think no one understands their pain, which is the total pain, not only physical but also psychological, social and economical, spiritual. And what we do here as psychosocial intervention is that we call upon family meeting. So what we can do is we not only gather information from the patient but also go with each individual in the family so that we can understand what's their perspective and what's their fears are. And even if there is any communication gap between the family members, we can resolve it through family meeting. Then supportive counseling is provided for the patient, and this is CBT based communication. That is CBT based communication. This is cognitive behavioral therapy based communication. In that we focus upon the rational thoughts rather than we try to eliminate the irrational thoughts and try to bring them back to the rational one. Then facilitating psychoeducation support groups. This is very effective, which I personally experience here. We have a paraplegic halfway home where there are paraplegic patients. So what we do is like when this paraplegic patients are brought into group, they started to share their experience where how they cope up with the situation, and this is literally helping the new patients here. So such support, psychoeducation support groups is very useful. If we can do that in our setting, that would be one of the best intervention. Then bereavement supports and services. We also have a bereavement support group here, where if the family patient dies and the family is still in grief, they are not able to cope up with the situation. We'll call them here, give individual attention. We'll talk to them. We'll understand their fears and we'll respect their feelings. And then they are introduced to a group who had similar experience. So there they'll share and maybe talk about their experience on the time of death and what they felt. So it will, just like the psychoeducation group, this will adversely help them to adjust with the new situation. Then recommendation for government schemes and other financial assistance, which is like mainly these patients when diagnosed with a chronic disease, having a long-term treatment is really threatening them. The financial income of the family is getting deteriorated, and maybe they'll relocate amount from other family household things to this patient care. So in order to avoid that, we can provide like there will be a government schemes available, so we can recommend for that, and also financial assistance for travel reimbursement, or education support. We can find sponsors, so those things can be looked into. Then linking with community resources, like if there is a volunteer or any other support group system in the community, in case of emergency, they can approach this link center, like community resources, and they can overcome that situation. Then vocational training, which is like we'll understand the situation of the patient, and we'll look into that. Okay, from this situation, what best can be done for the family. Maybe same thing, we'll ask the patient to suggest like what they think is going to literally affect, improve their quality of life. So some of the training we provide here is like umbrella making, then candle making, seasonal cards, then stitching, I mean tailoring, all these things are done. So we can also rethink about it, because each culture may be having different things. So according to your community, which is which can add to their income, not a big amount, but a slight amount, which will directly have a feeling that even with this condition, they are supporting their family. So that role can be preserved there. Then regular follow-up is one thing that we should know, because as we learned earlier, this psychosocial issues is an ongoing process. It can change in any time, so we have to see upon that and do the regular follow-ups, where we should assess the psychosocial issues of the patient and family members. Always remember that evaluate our interventions, like whether even if we give a support, vocational training, whether they are doing it regularly doing it, whether they are getting any benefit from that. So we have to evaluate each and every intervention we provided, how they got positive things, or what are the negatives in that. So we should understand those obstacles and act upon it. Then assess how the patient and family is benefited, and good documentation is invaluable. We have to document each session, because maybe psychosocial going through, since it's going to be an ongoing process, we may miss some of the important clues which patient gives us, especially about suicidal ideation. So we have to document each and everything regularly. Then whenever possible, use research validated techniques. For example, if it is like if we talk about the spiritual thing, there is a valid research tool which we use here. That is the Oxford textbook of palliative medicine, and that they propose a tool, spiritual tool, where we look upon the four main aspects, which is connections, relationship, then value, and then concerns about the future, all those things. So by doing so, this is regularly we are getting an idea about what the patient is. Later we can use this data can be published. So we have to use valid techniques. Then there is an there is psychosocial, it's an art and science in psychosocial care, just as in medicine. Right? We are going through different stories of patients. We are coming across new things. We are able to learn from that. Like it may be a new term, new experience for us. It's all because we haven't never gone through such experience. We'll be blind towards that. So when we listen to the patient, we are learning a new technique, and we are trying to solve a new story. So consider it as like this is psychosocial is really important in total care of the patient. So I recommend you to do the assessment very regularly. So we have Smriti Rana here. She's our mentor, like here. She's our senior, she's mentoring us, and she's a clinical psychologist. So now you can talk to her about more about psychosocial assessments if you have in doubt.
Hello, everybody.
Hi. Anybody would like to ask any questions?
Sorry, I've joined you late. Sherin, we finished with the dignity section. Okay. So if you like, I think there's also a case that needs to be discussed. So if our colleagues from Indore would like to then discuss that, then perhaps we can move into that. And then as we go along, perhaps some of the things that Sherin talked about, we can come back to address.
Smriti?
Yes. Hello, Dr. Sunil.
Hi. I think it will be helpful if you can give some of the important messages regarding psychosocial issues in palliative care, and then we'll move on to the presentation, and we'll
Okay.
discussion on that.
Okay. From the point of view of psychosocial care, I think through Sherin's presentation, a lot of points have been touched upon. What exactly is the role of psychosocial clinicians? And one of the things that Sherin has probably already discussed is that the idea is to look at the patient as a person rather than somebody who has just an illness. And I know we've also probably discussed how roles of a person changes as illness sets in and how it affects the entire family. Like also in the presentation, we've talked about something called total pain. I just want to revisit that because I think that is the central tenet of psychosocial care, where the pain that a person reports is so much more than just their physical distress or the physical symptoms that they're experiencing. It has to do with their life circumstances and how all of that is contributing to their experience of their suffering. So I would prefer to use the word suffering over pain because pain sort of limits everybody's concept a little bit. So the way we see it, we constantly talk about palliative care being an interdisciplinary approach. But most of the time, however, the focus is on the medical aspect, and the non-medical aspect is given a sort of secondary status. But more and more, we find that it's the non-medical aspect that really needs to be tapped into in order to make a better medical treatment plan also. They're in conjunction, and the role of a psychosocial clinician, whether it's a medical social worker or a psychologist or a counselor, is as important as that of the medical team in a sense. First off, of course, like Sherin said, the assessment is very, very important. Just how in a medical scenario, the right diagnosis is essential in creating the plan of care. Similarly with psychosocial assessment, because while medicine has a very clear-cut, scientific, research-validated sort of protocol that it follows, so does psychosocial assessment. And we start off with first looking at the family as a unit, which is why the genogram is so important. We need to know who is in that person's ecosystem. And it's not just the people that they directly live with. It's also, or their nuclear family, or their immediate parents, or blood relatives. it's also everybody in the family who plays a role in that person's life. So our genograms in palliative care are not just the nuclear family, but go on to extending to include siblings and extended family, their children, all of that. Because then that gives us also an insight into who we can draw upon to improve their support structure. It may not be the immediate family in many cases. To give you an example, a lot of our families in Kerala have one family member working in the Middle East. And they are the ones who are the breadwinners of the family. And very often at the end of the day, no matter what discussion is had with the family on the ground, it is the person who controls the money that becomes the ultimate decision maker on how the money is to be utilized. So even though that person is not physically living in the space with the patient, he forms a vital role in how the treatment and the plan of care is eventually executed. So we have to be cognizant of all of those things. If there are children in the picture, then very often they become invisible, because the focus is on the person who is unwell, whether it's the parent or whether even if it's a sibling of that child. And our role is also to make sure that we preempt any problems for that child, because the trauma of living with a family that has a severe illness will at some point manifest when this child grows up and his or her needs have not been adequately anticipated and managed. So that kind of thing also happens. And the idea is to contribute to the overall health of the whole family, not just the patient. Of course, the patient is the central point of focus, but that care is extended to everybody in the slipstream of that person. So in a sense, the work that the psychosocial clinicians do vastly help the core medical team in alleviating the suffering that the person is reporting. The other central tenet, apart from total pain, more and more we find is the idea of dignity. And dignity is a word like love or joy. Everybody knows that it's important and it should be a part of somebody's life. But when you actually go down to defining what dignity means to a particular individual, you'll find that the answers are very, very different. So in the presentation, there is that dignity question. What do I need to know about you that will help me help you better? And very often we find that when we pose that question to our patients, the answers are unexpected. So for instance, one person would say, my father abandoned my mother when I was a child. Now, what does something like that tell us about the patient we are dealing with? Probably that there is a fear of abandonment. And in that case, what can we as a team do to reduce that fear? We can reassure that person that we will not abandon them. No matter how this illness progresses, we will be there as a team to help him out or her out or the family out. And by doing that, you reduce a little bit of the fear so that the person is able to then, re-engage with life in a more healthy sort of way and increase their quality of life. Another answer you might get, which we have received in the past, is I'm a man of the soil. I've been a farmer all my life and now I'm here. I'm in this IP and I've completely lost touch with my land. And it's so important for me to see plants growing and, nurturing things like that. So in our case, what we did was we put plants in his room that he could look after. So it gave him something to look forward to in a positive way. It gave him meaning. In a small way, it gave him meaning in his life. You could get an answer like, I love ice cream, which means that simple pleasures mean a lot to this person. So at no point can we undermine or dismiss that particular aspect that that person sees as his dignity or his sense of autonomy. Very often, I think the focus is so much on making the physical distress go away that we forget about these things that contribute to making that person who he or she really is. And a huge fear that we see in a lot of our patients is the loss of control, the fear that they get from losing control over their lives. And very often we see it in patients who have been the breadwinners, who've been the decision makers, who other people in the family used to look up to. And now this person has no control over where his own disease is going and what it's doing to his life. So in that case, the effort is then to reinstate some kind of autonomy and some kind of control back to him. Some patients have no problem with their families doing things for them, from getting a glass of water to washing them, to bathing them, to feeding them. Whereas for some people, that act, which is good intentioned, can actually make them feel more like a burden. And that is a phrase, again, we hear quite often, that I don't want to be a burden on my family. So those are some of the conversations that open up. And there is obviously an art to having those conversations. They're not easy conversations to have, but that's where your psychosocial team comes in with adequate training. Those are the aspects that they should be looking into. And essentially, in particularly challenging cases, we strongly recommend that the interdisciplinary team sits down together and exchanges notes on what each of them has learned about the patient and the family, either from a medical perspective, a psychosocial perspective. They might have opened up in terms of their spirituality and what gives them meaning to somebody else on the team. So when we bring all these different findings together, that is what helps us create a plan of care that is holistic and ultimately more effective in reduction of pain. So if you're looking only to reduce pain through one means, it's, in our experience, it very rarely has the effect that a more holistic approach has. So that's the reason I think SHERIN has crafted this, brought in these aspects of total pain and dignity. And they seem like slightly nebulous or ambiguous topics, but just like a doctor or a nurse needs to upgrade their skills, so does a psychosocial clinician. With all the new evidence coming forward, it's our responsibility also to constantly learn and bring that to the table when we have our meetings regarding any particular patient. So can I get any questions, or I can proceed from there if you like?
Dina? Any questions?
No, it's a lot of information to digest, and it was a very it was a good presentation, and ma'am's talk also. I've never considered those things. So,
Dr. Bhatta?
I think if we perhaps Shiba, if we go into the case which they are familiar with, then maybe some of the things that we're talking about will become a little bit clearer, and then perhaps from there on, if there are any further questions, which I'm sure there will be, we can then address them in a more focused manner.
Okay. So the patient story will present Dr. Dina from Indo. So Dr. Dina, please. Yeah.
Am I audible?
Yes, yes.
Yeah. Hello?
Yes, yes.
Yeah. Should I start?
Yes, please.
Yes.
Yeah. Next slide, please. Yeah. Our male patient of 46 years old with an advanced stage of the left buccal mucosa cancer has taken a chemotherapy as well as a radiotherapy, and he already started the morphine. Next slide. At a dose of the 10 mg tablet, 6 tablets per day for 2 days, but there was no response for that. Then he took 12 tablets per day for the next 2 days. Then he came to us with a chief complaint of severe pain since 6 days after taking a morphine. Then we have taken a history and did a assessment of the patient. Then he told at last ki I want to live with family, but my family kept me alone in a room. So after calling his family members, we counsel them, and patient went to his family with the pain medicines. Then patient came after 10 days with a smiling face and a pain relief. Now he took only 1 to 2 tablets per day of morphine SOS for the pain since 3 days, and patient is happy now. And we call him 10 days back. He's on a tramadol SOS. So how I will do a further management for his problem and pain, and what were the more causes behind his relief.
Family, who is in his family? Sorry, I think I was muted. Yeah, sorry. So Hina, I have a couple of questions. One is that when we talk about this patient's family, who is in his family?
Wife, sister, mom and dad.
Okay, wife, sister, and they all live together?
Yeah.
Any children?
No.
Okay. And who is his primary caregiver? Who looks after him on a day-to-day basis?
Dad, but not
Okay.
that much.
Okay.
That's why they kept him alone in a room.
Which I didn't understand that. He was kept alone in a room because?
Means he was from out of Indore, and his family kept him alone in Indore for the treatment.
Okay. In the hospital?
No, in a room, separate room, like a guest room.
Okay. I want to ask because, I'm not a doctor, so I need to ask a few simple basic questions. Cancer of the buccal mucosa would mean a head and neck cancer, correct?
Yeah.
And so what was, if you can just describe what he looked like, what was the extent of the disfigurement?
It's in the buccal mucosa involving the cheeks and the gums.
And it was an exposed wound?
Yeah.
And a foul smelling wound, I suppose? No? No, so it wasn't, but it was an exposed wound.
Yeah.
Okay, so that's one. The reason I asked that question is because very often when there is a head and neck cancer, and especially when there's disfigurement, that automatically leads to a fair bit of shame and embarrassment, not just for the patient, but also for the patient's family. Yeah, and he's lucky if this was not a foul smelling wound, but I'm assuming just the visual of it was quite frightening for the people around him and for himself. We also find very often that patients with head and neck cancers do automatically withdraw quite a bit, and sometimes there is isolation from the family because it's hard to see somebody like that with that, because it's not like the wound is in any other part of the body that can be covered up and hidden. It's literally in your face, literally and metaphorically. And So what I would like perhaps to look at in this sort of scenario is that could the visibility of his wound itself be a contributing factor to them not wanting to be around him? Not because they are disgusted by it. I mean, disgust could be a part of it. Let's not, when as palliative care professionals, sometimes we only want to look at good things about other people, but there are certain emotions like disgust, fear, anger towards the patient that nobody really wants to talk about because it's not socially acceptable to admit to those feelings. But there could be a certain amount of disgust associated with it or shame associated with it. And the other thing is probably helplessness, not being able to do anything about it and looking at it day in, day out. So I'm just wondering that may be a contributing factor to the isolation of this person. That's one thing that I would like to I would explore a little bit more. And how I would explore that, if you're asking for a plan of care, is to probably call aside, first of all, find out who is the primary caregiver to him. Usually in a lot of Indian settings, it's the wife or the daughter-in-law. In this case, because he has a wife, I'm thinking that most of the tasks would be assigned to her to do. But again, that's an assumption. That is something that you will have to check. So my first suggestion would be to draw a proper detailed genogram, and then to see who is the primary caregiver to him. Then perhaps have a conversation with that person on a one-on-one basis and try and elicit what it was like for that person. Say in this case, assuming it's the wife, what was it like for her on a day-to-day basis to see him like this, and what was expected? Because if I'm expected to help with dressing a wound or cleaning it or whatever, if I'm not trained to do it, then I'm really going to have a lot of reservations about it. And I might also say, ठीक है, मुझे करना ही नहीं है क्योंकि मुझे आता नहीं करना. So, that sort of thing. So try and explore the primary caregiver's responses to being in that role from a very objective point of view, and create an ambience where that person understands that it's a confidential conversation, that what is said to you will not be repeated to anybody else in the family. Maybe that person will open up to you a little bit more, and that will give you insight as to why the isolation took place in the first place. It could very well just be a financial issue. But I'm saying from a psychosocial point of view, this would be something that I would definitely look into. In one of the paragraphs, it has been mentioned that the family was called and counseling was given, and then the pain medication was given and he was sent back with them. I would just like to know a little bit more about what that counseling involved.
Counseling was that patient was very much depressed. So we counsel their family members keep him with you, as it may be a psychosocial involvement may be there. So they agree for that, and after 10 days when he came, he was very much happy for the pain.
Okay. Okay. So from what I understand, they were told that he's depressed. Was any conversation had with them to find out their point of view on or their difficulties in looking after him? Is there anything about him or keeping him at home that was difficult for them?
Not like that.
Okay, so that's another point that I would probably recommend, that the next time you have a meeting with the family, try and understand what their difficulties were, because there could be something there. When somebody is when someone is depressed, it's not it's very rare that it is something that is not happening within a system. So I think our role is to find out who is part of that system and how that system is functioning, that is contributing to this depression or making it get worse. So in that scenario, it's not that the patient is a victim. Everyone in that family must be having their own sort of challenges that they're facing emotionally in looking after somebody who's so visibly unwell. So maybe what I would try and do is, of course, talk to the primary caregiver one, but also have a conversation with some of the other family members to find out some of the dynamics within the family. Does he throw temper tantrums? Is he difficult to be around? When he's in pain, does he abuse people? What does he say to them that makes it difficult to be around? And so those kind of things, because I think by being compassionate to what they are going through and then taking away some of their distress, we then empower them to become better caregivers for him. Because if I tell them, take him home and make sure that he's not depressed, that effect may last because it's coming from an authority figure like a doctor. That effect, they'll go back and they'll manage for a few weeks. But after a while, whatever the source of the problem was will re-emerge. So unless we find out what their dynamic is and how we can make it better, I'm afraid this may become a loop where he'll get better for some time, then he'll go back, then things will get worse again. And in that case, like you mentioned in the case study, that he had to use more and more amounts of morphine, but when he was happy, his dose of morphine actually came down. So there is definitely a psychosocial element at play. It's not just a possibility; it is a definite thing that is happening. Because if he's happy, he needs less medicine, right, to manage his pain. So let's find out what that is. And what I would also ask him, if he came back happy, is what was different this time. What was different this time? You've come back a couple of times not feeling so great, but this time you've come back. So what has been different at home to make you feel happier now? So that will give us insight into what has changed on the home front that has contributed to his needing less medication. So that is definitely one area that needs to be looked at. And ask the family their ideas about the disease. To educated people, some educated families we have, sometimes will believe that cancer is contagious. That has happened several times, where they believe that the disease is contagious or it's inauspicious, Abshagun. So try and find out what their ideas about the illness is. And if we find that some of these, myths are there in their heads, then maybe, getting rid of those myths and explaining to them that, see, this is not a contagious disease. This is not a sign of punishment from God. This happens to people from all walks of life. If we can get past those myths, sometimes those could very well be the root cause of this kind of family dynamic that is emerging. So I think our job as professionals is also to try and find out what myths the family harbors about this particular disease. And let's face it, in India, that this is something that is a very real possibility that you could be facing when it comes to some of the families that we deal with. So those are some of Sherin, Litin, any more inputs from your side?
So said that the father is looking after the patient, and I just want to know, is it his own father or his wife's father? And
Father. Father.
His own father.
His own father. And he is out, you said that he's from, not from Indore.
Yeah.
So they moved.
Their hometown is out of Indore,
Uh,
but they keep him in a room, in a guest room in Indore.
And the family is not with him. So are they hiding it from their community?
Maybe.
So if we
So
look at
I'm going to take up from that, Sherin, because that's a very important point. Are they hiding him particularly from their own community? The reason for that could very well be a myth or a superstition. Okay, and that could very well be the main reason. Now, they've taken him back and he's been happy. So we need to know what is different between the last time and now. That's one. Also, it might be pertinent because we keep forgetting that, you know, these were people before they became patients. And we need to go back to what kind of people were they before the disease happened. You know, how was the relationship with the family before he was diagnosed with cancer? Was he, you know, usually you'd think that the son in a family has a pride of place. But when he's sick, usually what happens is people will do whatever they can to look after him. So this is a bit of an unusual situation where the son is not well and they've cast him out. So is there some history in the family that that maybe there was a difficult relationship before the disease itself came, and this was just the ideal sort of scenario where, you know, using the disease as an excuse, he has been sent away from the family. He's 46. They don't have children. That to me is conspicuous by its absence. It's not usual that a middle-aged person does not have children in this context, especially if they come from a more rural part of the state. So the absence of children is surprising to me. Maybe there is something there to explore. So try and find out what the dynamic was before this person got unwell, and were there any, you know, habits that the family didn't like. Was he a disruptive person in the family? Was he a well-loved person in the family? Was he contributing to the family's welfare in any way, or was he just draining them of resources and, you know, being a lazy son? Was he heavily drinking? Was he, you know? So those are the kind of things we need to understand about him before he became sick, which might be contributing to why this particular dynamic is happening now. I'm just going to go back to the fact, at the cost of being repetitive, that the fact that he needs less medication because he's happy is a very, very important point to see. Because if he's going to be unhappy, and if the family is going to be unhappy, and their unhappiness is going to cause him difficulties, then I guess medication is not going to be as effective as we think or we hope that it will be. So try and understand what he was like, what was his personality. Ask him, like, you know, how do you see yourself? And what are your strengths? What are your aspirations? And how have things changed ever since you got diagnosed with this? Because quite often the answer is not so much that, oh, now I'm a cancer patient. They will actually tell you how it has affected them as human beings to now have this illness to live with. So that's an important point. What was the kind of person he was like before? And always, in all your exploration, try and talk to as many people in the family together, because everyone will have a slightly different point of view. So it's like putting together a jigsaw puzzle. If you take only one piece, you're not going to get the whole picture. But if you get different pieces from everybody in the family, maybe some people in the community, and then you piece it together, then you know where the problem lies. Are they a religious family? Are they very religious? And if they are religious, then do they follow any kind of religious leader? What does that religious leader feel about somebody being sick with such a visible disease? So those are some of the things that might be contributing to how this family is behaving together. Because 99% of the time, if a family has been cooperative and cohesive before an illness, then they cope better after the illness has happened. But if they were a dysfunctional family before, then an illness comes into the picture, the dysfunction only gets worse. That is a thumb rule most of the time. So we need to find out what the family, how they operated before this illness came into their lives. So that is something. And I would also try and very sensitively broach the subject of why there are no children in the picture. I urge you not to go and ask directly, why do you not have kids? Because it could be a very difficult question to answer. But maybe in a roundabout way, try and tap into that. It could be a source of disappointment to the grandparents, especially if the person is his son, if they're his son. So that is something definitely that needs looking into. Also, how old is his father? Any idea?
70 or 65, 65, 70.
And how is his health?
Good, matlab, working man.
Okay. So he is now the breadwinner in the family. He's the one earning money. And the sister is not married?
No, unmarried.
And she must be how old? In her 30s, 40s?
20s, 30s, I guess.
Yeah, because he's 46 and she's his only other sibling. So I think maybe she might be in the 30s. It'll be good to know what her age is. Now there again is an unusual dynamic for a typical Indian family, right? For a woman, I'm sorry, I'm sounding like all my stereotypes, it's all sounding very stereotypical, but I'm just saying that this is usually the norm. I don't sort of prescribe that women should be married by this age, or they should have, or families should have children. But I'm just saying, going by the general norm in a community, this is a bit outside the norm, right? You have an unmarried woman in her 30s, or whatever her age is right now, and this couple doesn't have children. They're all living with the parents. So that is a dynamic that may be a little bit unusual. So we need to look into that and see what's going on there. And if that is adding to the burden, because if the father is 70 something years old or 60 something years old, and he's still looking after his two children, one of whom is very sick, it could, like I said, very well just be the financial burden of looking after this, of his son. So let's try and find out what exactly is contributing to this dynamic. And perhaps if it's a financial concern, then how we can then take steps to get them in touch with subsidies and government schemes that might help them. If the sister is able-bodied and is mentally sound, then perhaps a little bit of vocational rehabilitation for her so that she can do something small out of her own home that might contribute to looking after the family's finances a little bit. If the wife is sitting at home and not doing much, then let's try and see if there's something that she can be taught to do. So just to reduce the tension and reduce the overall burden that this family is going through, maybe a good approach in this particular scenario. I'm not sure if, do you have access to some sort of vocational rehabilitation agencies for women?
No.
So maybe in Indore, to look for something like that, where there are women's groups that help with training women in doing small things. Like in Kerala, we have everything from umbrella making to soap making to whatever, even catering, so many things that don't actually require, they might require the most minimal amounts of skill training and development, but it also gives them a sense of empowerment. They also feel less helpless. And so maybe looking at those kind of agencies. And so even for future cases, when you find marginalized women in some of the families that you're seeing, perhaps these are agencies that you can tap into and collaborate with, and that will take some pressure off your team as well. Because if you are so, it's very hard for a team that is fully focused on families that are unwell to also do this. So maybe a good idea is to collaborate with other groups that are already doing it in your city, and then sort of create a system where these two can be put in touch. So that might be something that you want to look at. Sherin, you do a lot of work like that. Maybe do you want to just tell them a little bit about some of the government schemes that we look into when it comes to children and women and marginalized, and even with some of our paraplegics and quadriplegics in our care, some of the schemes that we put the families in touch with?
while looking from the Kerala context, we have the small self-help groups, which is like in the community itself, women will become a collective form, neighborhood group. And what they do is they apply for a loan, which is like as a collective. So it will be like they have less interest in that. They have to repay it less interest, low rates, and it will be like they'll share equal. And another way is like we can sensitize the community people, like mostly women, and ask them to start a small like piggy bank thing where each week they'll come and put a small amount, and or maybe dal, rice, anything like that they'll share, and which will be given to some of in that group who is like a very socially economic, very low person. So for that family, they will spend on that. And the next time, the other person can take the turn. So we create groups. We have like it's running very well. And also, I have heard that in Northeast they have the Grameen Bank system, where this it's mainly focusing on the women empowerment. Where the same thing is happening. This group is like it's an agency which started like providing training for the women in empowering, mostly on like tailoring, all those things, and they are getting loans on that too. So one thing I would then we have cancer pension from state level as well as central level, which is like we can just go through the Google things. Here in Kerala, it is like Karunya scheme. I have to search on in your place which is most availing for that. So which is a small amount, 1,000 rupees per month. But maybe some 2 or 3 months they'll skip that, but they'll get it as a collective. So that will be also useful. And if the patient is bed bound, they are having assistance from the local self-government. So here we are getting a support from our local self-government. So you have to check that also, whether in your place it is availing or something like that. And one thing would be like, recently I have gone through an article in government. It says that they are providing free education for women, very low, like low education area. So they are providing short courses where they are trained to write like the basics of education. So you can look upon that too. So that for the sibling, we can see how whether she had done her primary education or something like that. That gives a glimpse of their family thing. Whether they are educated, they may have some idea about this disease. So it will be easy from our part to reduce the stigma. I guess so. I want Sridhar to.
No, that's a very good point. I've just been thinking about this why she might be at home and still a spinster and stuff like that. Maybe we need to check what her functioning capacity is. Is she mentally sound? Is there some other challenge that she might be facing physically or mentally or emotionally? Could there possibly be some psychiatric issues there that need to be looked at? Because if we're going to go in and suggest something like vocational rehabilitation, we need to know that the person who's receiving it is able to do what we are proposing to do. So always first check the capacity of the person, what they're capable of, and then make appropriate and relevant suggestions. But definitely, look into, because every state has their own schemes. There might be schemes available in Kerala that are not available in Madhya Pradesh. So I'm not very clued into what is possible there. But I'm quite sure that there will be the women's groups or vocational rehabilitation groups. It doesn't even have to be a vocational rehabilitation agency per se. It could very well just be a volunteer in your community who is willing to teach them a skill. Some of those people become pretty vital in developing your community, that will that will take on some of the roles of the palliative care team. I think one of the most successful things about Kerala has been its ability to tap into that volunteerism. We find that if we are able to help a family in a way that they need it, and even if the patient eventually passes away, that family has a lot of goodwill for what work has been done, and very often they come back as volunteers to help take this forward in their community and to tell more people about the services that are being given. They may also often come and volunteer their own time. There's a lot of volunteers, if I'm correct, Sherin, who've come in through our bereavement support group and are now have been long-term volunteers with Pallium India. So that is a whole mass of people that, if they are helped correctly, they will come back and be, your own force to go out there and help out in areas where you may not have time to go out and do what they can do. So that is definitely an area that is a very crucial area to look at. The bereaved afterwards, or even now, like if this family is helped, then quite likely you are creating champions, no matter what their economic status is, and you're creating champions for the cause of palliative care and for what you're doing. So that's a very essential group of people to look at. Do you have, I want to ask you, do you have social workers on your team?
No.
Okay. So there is one challenge there, which is staring us in the face. And it's easy for us, I think, to tell you to do all these things, but your main challenge now would be to probably have a social worker come on board, who will then, look at all these challenges, because you may not have the time or the bandwidth to do some of the things that we're so happily telling you to do. But what we need is obviously a social worker. So I would consider that with some sort of urgency, because it's very clear that you want to help this family. But in order to do all these tasks that we're sort of discussing today, you will need a person who is appointed specifically to do it. Because if it's something that only you or your immediate team members do when you have the time, then there is no follow-up, there's no regularity. And these kind of things, like was mentioned in the presentation, require a lot of documentation, because going forward, then these will help you form the roadmap of things that you have learned, things that need to be done differently, but you need to have a particular person for that. So having a social worker on board may be a good idea at this point, just to make your workload a little easier. I think we have another 15 minutes, Sherin, Shiba.
Yes. Any questions?
So, so I think, sorry?
No, any questions?
Yeah, because I think from our side, we've talked a lot. So if we can get some feedback from all of you, if there's anything in particular that you want us to help with going forward, or anything that we said that did not make so much sense in your context, then probably this is the time to have that conversation.
Ma'am, what is your experience with dealing with spiritual issues? Ma'am, have you dealt with people who have specific spiritual needs?
That has come up on several occasions, because I think Sherin would be the right person for that, because Sherin and Litin are the ones who are now on a day-to-day basis doing a lot of clinical work. My clinical work is with them is quite intermittent, but I'm more in the academic and training capacity. But in terms of spirituality, it is I'm so glad you brought that up, because a lot of people are not comfortable going into that area because it's, again, ambiguous. We use something called the spiritual assessment tool, which is the Oxford spiritual assessment tool. Obviously, you'll have to modify it a little bit to fit the Indian context. But we have found that tool to be quite effective in helping us get insight into how we can help that person's spiritual anxiety or spiritual distress. Sometimes it's very important to make the distinction between the fear of death or death anxiety and the suffering that they are going to experience along the way before they get that. So sometimes the spiritual distress is more that. There are oftentimes people who've been deeply religious and they've been good people through their lives, and then this happens and they cannot understand why this is happening to them. Why is this happening to me? I've not done anything wrong. They see it almost as a punitive, punishment sort of thing that's happening to them. We see spiritual distress in children. That is a group that we don't, most people don't think that children think along those lines, but in their own way, they have their own idea of what is meaningful to them. And so when we talk about spirituality, I just want to reinstate that it's not only a religious connotation. Spirituality will also bring in aspects like music, nature, their relationship with the world, their ideas about a higher intelligence, not always in the form of a particular systematic religious tradition. So our experience has been very varied, and I will confess that we are also learning. We are by no means experts. I don't think spirituality is a field that any of us can become experts in completely, because it's such an individual thing. But a word of caution definitely, which all of us try and practice, is that our own spirituality and our own beliefs at no point should filter into our interaction with our patients and their families. Because that is, when a patient or a family asks you, what would you do? It's very important to state that this is, well, what I would do is what I would do, but let me help you figure out what works for you best. So that projection, unfortunately, we have such little time. This will require another hour of discussions. But Sherin, some of the more, I think maybe if you can illustrate with any particular case about how we have dealt with spiritual anxiety and spiritual distress, maybe it would be good for it to come from you.
So while when I have a good rapport with the patient, I'll go through I'll do the spiritual assessment, not in the initial phase, but it's a simple question. You can refer to that. That is in the Oxford Book of Palliative Medicine. They prescribe a special tool, spiritual assessment tool. In that they are given small questions where we can ask them in person with the patient. So this cannot be in a order like you have to go with the tool and sit with them, then read the question, not like that. But in general way, you can ask like, what is the most concerning thing for you? Or when you have a challenge, who the person you go for help? Or what is the most you're thankful for? Or so by saying that, maybe these questions may be asked for the first time to the patient, and they are going back to a life where they had overcome maybe a big situation, and they had an image of their own, like I have accomplished this and my achievement is this one. So when we walk out from the door, actually at the time of illness or that problem, they are only focusing on the problem, not their achievements or their past life happy moments. Nothing will be on their side. So when we ask this question, we are opening a door where they had gone through the good memories, and they are at least thinking about that. Okay, I have overcome these problems, and they'll get an inner strength. That was our belief. Okay, I had different experience with patients. Like when I was interacting with the lady who had diabetes, and she was abandoned from the family. She was staying in a home. She said that I asked her what was the most happiest moment in her life. She told me that she had 3 stepsons, and she was when she was diagnosed with cancer, she was going on an auto rickshaw with the younger son, and suddenly the auto driver jumped into a gutter, and she got pain episode. Suddenly this stepson shout at the auto driver, and that is the most happy moment in her life, where someone had come up and fight for her. So we can imagine a lot of strange things. For me, if you ask me what was the most happy thing in my life, I would say that I got an award in doing my program, education time. That would be the most amazing thing. And that's why Smriti ma'am told you, like, our judgment should not interfere while we are listening from a patient.
I think, yeah, thanks, Sherin. I mean, you said it really well because, like she said, I'm just going to reinforce it that when the disease is the focus, then the disease is all that is seen. And it's very important for us to help them re-engage with who they have been. And like that question, if you're in trouble, who is the person that you draw your strength from? There's a whole series of very simply worded questions there, which if you look it up, I will also encourage you to do the spiritual assessment tool on yourself first, to see just how effective and how powerful it can be. And the other very important point, and that's something that we all do as part of our training, any new MSW trainee comes to us, we make them do the spiritual assessment tool for themselves. And it's only when you experience its power that you understand what you're trying to do with the patients that you work with. But like she said, the very important thing is don't try and immediately use that spiritual assessment tool because rapport has to be built. And, because if they're going to be telling you something that is so intimate and so important to them, it needs to, that atmosphere of safety has to be created first. And that can only happen with one or two rapport building sessions. But look it up. If you like, Sherin, perhaps we can email that spiritual assessment tool to this group, and you can all have a look at it, see how you can tweak it to your context. The language, of course, will have the nuances of the language that the patient understands. Very, very important is when we sometimes force our language on them and they don't understand, then we think that they don't understand. But if once or twice they're not understanding what you're saying, it's time to rephrase yourself in a language that they will understand. So those questions, I will advise against using verbatim. Use it in a way that is contextually appropriate. Use it in the language that the patient best understands. And once you start using it, you'll find that a lot of avenues open up in understanding spirituality and its impact on the distress that a person is feeling. So that's like I said, that's a topic that we can have a very, very long conversation about sometime. Perhaps not today, as we are running out of time. But thank you for that question. It's an important one.
Any questions?
Ma'am, any quick pointers on dealing with children stuck in these situations, just for 5 minutes?
Quick. Okay. Dealing with children in a scenario, quick pointers would be: one, please understand that all children understand the experience of illness. It is an adult patronizing attitude to believe that a child does not understand and need not be told. There is a tendency to protect children. But by protecting them, what we are doing is distancing them from realities of life and creating fears. Children will, if they're not given the information they need, will fill in the gaps with their imagination. And very often, their imagination is far worse than the reality. So one is always believe that a child does understand. They understand it differently from how we understand it, but they do understand it. Two, try and look up developmental milestones of children in terms of cognitive functioning, because a child who is, say, 3-4 years old takes everything literally. Like if, for example, somebody dies and they said, what happened to grandma? And you say, oh, she went to sleep and she never woke up. That child might just develop a fear of falling asleep because they take it literally. Or if you say, oh, she's gone to be with God, God took her away, this child is going to think, okay, God is not a nice person or entity. Why did he take away someone who is important to me? So there's a lot of you have to take a lot of care in the language you use. An older child may revisit the same issue with a different question, because now he has a better or a different understanding, has more cognitive skills, has more language skills, so it's able to ask the question differently. So one is to explore the developmental stages of childhood and how language is understood, and then tweak your language to fit the developmental stage of that child. That is very, very important. Never talk over a child's head to the parent when the child is in the room. It's very important to address the child directly. No, don't ask the mother or the aunt or the father, what is he feeling right now? The child is in front of you. Ask him what he's feeling. The answer may not come quickly, verbally, articulately, but observe non-verbal behaviors in children, because very often grief comes out in the form of behavioral differences. A child who has been a perfectly happy-go-lucky child will suddenly be more withdrawn, will start having more fights in school, will start failing at a subject that he used to do well at. These are all things that are signs of grief. Even anticipatory grief. The person may not have died, but there is tension at home because somebody is sick. Look out for these behavioral differences, because that is going to give you a clue as to how this child is processing the event. When a parent is not well, I strongly recommend that the child is spoken to by a compassionate adult and explain what is happening. Now, a lot of people are afraid to take a child into a room where a sick person is lying in bed and there are tubes and stuff. Instead, sit with the child and say, we're going to go in, your mother's inside, there are some tubes in her, those are tubes through which she's getting medicine, it's nothing to be afraid of, it's making her feel better. And so prepare the child for what they're about to visually see, so that when they go in, they have some sort of idea of what they're going into. It's not a shock to them. And they're also being brought into the family's interactions. By leaving a child out, you're only isolating the child. You have to engage the child, even with an ill person. If it's a parent who is sick, again, if the child is quite young, I encourage you to have that child come and do normal things around the parent who is sick. Bring some homework, sit there, draw something, do normal activities around the sick person. You have two benefits from that. One is that the child starts to process the illness better. There is a sense of normalcy to what is happening. There is an underlying normal thread. And what it does for the patient is makes them feel a little bit better that they're still part of that child's life. So there are two very, very big benefits out of compassionately educating a child and preparing the child to deal with someone who's not well. So those are my quick pointers to you. Again, we can revisit it in more detail. Maybe we can have a conversation some other time if this is something that you're interested in. And it's a very, very important area in my opinion. So I'm happy to have that conversation at another time.
We stop here. Thank you for your participation, and thank you, Sherin, for the wonderful presentation, and thank you, Smriti, for your valuable suggestion and input. Anyway, our next echo session on next Tuesday. That is our last session. So try to join us, and then your feedback and suggestion is important to us. So that time we will discuss about that. Anyway, have a nice weekend. See you on Monday.
Thank you.
Thank you.
Thank you, everybody.
Bye.
All of you.
Thank you, ma'am.